Hello and welcome to the Voyage Clinics podcast. I'm Dr. Shaunna Sanders, family physician, and today we have my very favorite guest of all time with us on the show today, Mrs. Shaunna Sanders. She is a JD MBA. She has multiple accolades. I'll let her talk about those. But our mission, again, with the Voyage Clinics podcast is just to help families learn and grow in the community. And Shaunna, just give us a brief introduction about your journey.
Hi, I am Shaunna. I do have a JD MBA from BYU that was acquired later in life. I think that on this podcast, though, I'm more coming as a mother of 4 kids, ranging from age 14 to 21, having, been in the trenches with the babies and the toddlers and the elementary school age kids and trying to navigate modern life and raising children to be, as healthy as we can keep them. And so I think I'm showing up today as a mom with a family doctor to help me raise kids.
She's so much more than that. So she got a master's in English, undergrad in English. She's a great dancer. She's an author. She's written a few books. What else about Shaunna? She likes to run.
I like to run. I'm really into fermenting stuff. I've perfected sourdough. That's pretty good. And I'm making kombucha.
We call it the booch.
And that's right. It's delicious. And it's so healthy for your tummy and your gut.
So we say.
Yeah, I'm always just, picking up little hobbies.
Kimchi, also awesome. Mm-hmm. We have a lot of kimchi at our house.
Yeah, we need to make some more.
I went to the dentist and he said, I can tell you eat kimchi. I guess he says, I work on some Koreans and they all have like kimchi teeth.
Kimchi teeth.
Because the acid in the kimchi kind of makes them more pronounced or something. Yeah.
Okay.
Yeah. No cavities, just kimchi teeth.
Kimchi teeth. Awesome.
Well, today we're going to talk about a whole bunch of cool things. And one of which is just navigating life as a mother. We had Shaunna had 3 home births. She delivered 1 baby in the hospital while I was in residency on call that night. Her journey in raising these children has largely been alone. And that's been hard for me. This profession is very demanding. But she's been really awesome. And so I wonder if you could share with us how your healthcare experience has been. You've kind of engaged in non-traditional healing stuff with both of our moms are very into alternative goodness.
Yeah.
But then also maybe when you have had to engage in the healthcare system, maybe when our kids were small, I was in med school and you went in, what those experiences were like and what that might have, how that might have influenced you a little bit. And then once I got my training done, what that might have changed, what that change might have been like to have like, okay, now we have like a family physician for our family.
Yeah. One story that comes to mind is when our second daughter was born. She was only a few weeks old, I think, when she was born. And I think it was a normal birth, but I took her into our pediatrician for a well-child visit at 1 week or something like that. And the pediatrician noticed that when she inhaled, her throat would collapse. And so was maybe worried that she had something that was not properly developed inside her throat, I'm guessing. I don't know. I was kind of sleep deprived. I just had a baby at the time, and John was in his 4th year of medical school.
It's called chondromalacia of the trachea. Mm-hmm. Some kids, when they're born, their trachea is not as firm as it should be.
Yeah.
And so it just becomes a little floppy. And sometimes when they inhale, it's called an inhale stridor. So, or they'll cry. And she would cry, and then she would inhale and she'd squeak like that.
Yeah.
And I think that was the thing that we brought to the pediatrician's attention.
Yeah. So he suggested that I take her and admit her to the hospital. So I don't even remember what happened to our other children. They were very little. Probably had a friend or someone watch them. We went to the hospital overnight, and it was just we were just we're just hanging out at the hospital waiting for some specialist to come and see her. And she's a newborn, and I'm trying to get some sleep, and I'm trying to recover from, delivering a baby. She was born at 3 a.m. also. Got to note that. So then finally, I think we got the otolaryngologist.
Yeah, ENT doc or
ENT doc,
otolaryngologist.
yes, that came the next day. Like we got admitted that night, but he couldn't come to do anything until the next day. And then finally they did a procedure where they put a camera through her nose, maybe, down her throat to look at her larynx to see what was happening. And I was all by myself in all of this. And there was the pediatrician, I think he maybe stopped by the hospital to say hi and see if he could speed things along, but it just felt like I was stuck in a difficult system to navigate. And I'm fairly sophisticated and educated, but I still was completely out of my element. And it's really a vulnerable situation to be in with a newborn baby. And I feel like that was one of those situations that probably a lot of moms have been in those kind of situations, and they're stuck in this big healthcare system trying to do right by their child. They didn't go to medical school. They don't know what's up. They don't know how to navigate that system. And on your own, it's very difficult. So when you were in medical school, that's one story I remember that had a strong impression on me. It turned out she was fine. She did not have whatever that was, and she still breathes very well. But
She's a good singer. She's a good singer.
Yeah, it was a harrowing 24 hours when I was in the midst of all of these machinations, and I didn't have much control.
So the training of a family physician, I want to talk about family physicians.
Okay.
Vintage-wise, like the old school docs, right? You think about your doc, your GP, this old, 50 years ago, this doc who used to come to your home, and he used to be very knowledgeable about lots of things and help you with various things and help your family kind of navigate healthcare and things. That's kind of the idea of a family physician, and that's my specialty. And so in medicine now, like medical education is 4 years of medical school and then a residency in something that you're going to specialize in. Way back in the day, they didn't have that. They would just graduate med school and then generally practice wherever. And if you practiced under a surgeon, you kind of learned that skill set and you became a surgeon. Now, each of the specialties and subspecialties are very compartmentalized. Family medicine continues to be a jack of all trades, and the training hours-wise, if you calculate the hours, is roughly between 15,000 and 20,000 hours of training. They put a cap on the hours during residency, and we do have to sign off on those caps. And so whether that means we obeyed them or not is another story. But 80 hours work weeks during residency is very typical to sign off on, and it's hard. It's a long, hard slog. Family medicine doctors train in emergency medicine, internal medicine, which means taking care of people while they're sick in the hospital, including the ICU, which is the sickest of the sick people. Now, there are subspecialists in these spaces too. So there's intensivists in the hospital who that's all they do is care for the ICU people. And there are ER docs who that's all they do is ER medicine. Family doctors can. I have worked in an ER. I've ran the ER before. I've managed patients in the ICU, even in a collaborative role with the other specialists and things like that. And then we're also very well trained in a lot of the subspecialties. So dermatology, pediatrics, OBGYN, sports medicine, just rheumatology, oncology. And I would say a jack of all trades. And when we get to the end of the jack of our trade, or the end of our knowledge base, then we might scale that up to, hey, I need a rheumatologist help in this situation. I've done X, Y, and Z things that in rheumatology that I'm familiar with, but I would like another set of more specialized eyes to collaborate with me on managing this situation. But we never give it away. We're not like, okay, well, now you're their patient, right? Now you're their client. We are your family doctor. We're there with you, continuity for the rest of your life if you would like. And we're advocating for you among all these specialists. We're journeying with you. When I send somebody to go see a subspecialist, I'll get their records back and I review that. I say, oh, this is what the rheumatologist was thinking. Okay, that jives. I agree with that. Great. And then I'll see the client back and then we'll talk about it. And then, discuss next steps in helping them move forward in their lives. So it's a very arduous journey. It's very fun. It's very satisfying. I get to learn my whole life. I go to continuing medical education conferences and I get to learn new and exciting things and understand new and different things and really broaden my abilities to kind of help people. So I just wanted to talk about kind of what a family physician is and then how to utilize them. So family docs are very well trained, and often people are asking me. They often come to me and say, "You do that too?" Yeah, I've done that for years.
Yeah.
They're like, "You can manage my thyroid?" I'm like, "I manage thyroid all the time. I'm very comfortable with thyroid." Diabetes, like you do diabetes management? Yeah, you don't. Yes, absolutely.
Yeah.
Now, if it's super, super complex and there's a super tricky situation, then endocrinology, come on in. Let's have you see them once a year, adjust your plan, make any tweaks to your plan, and then come back to me and we'll keep on managing. So I want to talk a little bit about, how do you utilize your family doctor? And the first thing is understanding what their training is, what they can do, what they can't do, and then the next steps in utilization. So maybe, Shaunna, you can speak to utilizing a family doc.
Well, so I can tell you the ways that I've utilized a family doc in our family, and then maybe you can think of ways that other patients have used you that I haven't, thought of.
Yeah, sure.
Obviously, so like broken bones and cuts and scrapes and things like that.
Mowing the lawn.
Yes. Mowing the lawn
No,
barefoot.
That's only because I'm your husband.
Yeah. No. So I think definitely like for overall wellness, I know that I've had visits with you and we've done lab work and we learned that, you may have familial hypercholesterolemia. A statin is really going to be helpful to you, in addition to diet and lifestyle modifications. And we've looked at, hormone levels or maybe my vitamin D levels or all of these different markers in my blood that my family doctor can look at and say, these are affecting your overall health and wellness, and we can do this sort of supplementation or these pharmaceuticals or this lifestyle modification to help improve these numbers and improve your overall life. So, and I thought everybody did that, but I don't think so. Like when I step outside of my own little bubble world, I don't think everybody knows that they can those well visits are actually really useful. It's not just to get like a clean bill of health so that you can play football. It's to look at how is your health doing? How is your body doing? Right. So let's go.
I've got a quick story.
Yeah.
So at the Voyage Clinics, one of the things that we do is get to know our people really well. And as we have more and more understanding of that person, their hobbies, their interests, their lives, it allows us to take better care of them and to establish more trust there and more faith there. And one thing with you and I, we've lived together for a while. We have a pretty good relationship. I noticed one time we were on a walk together and we were jogging up this hill and I thought, whoa, what's your heart rate right now? Because I just noticed your breathing and I was like, whoa, what's your heart rate doing? And you're like, oh, it's like 180. And I'm like, well, is it always that way? Because you have these nice watches and stuff that you wear when you're working out. And you're like, yeah, pretty much every time I go running, my heart rate goes up to that. And it won't come down. Like, it's always super high.
It just hovers in the 170s,
And
180s.
And I said, well, that's not super weird. Even a light jog? You're like, yeah. And so I said, well, how long has it been doing that? A long time, like ever since I can remember. And so we talked about like, maybe it's a heart thing. Maybe there's a weird heart problem. And then I just said, well, there's a couple things that create an increased heart rate. And one of them is your lungs. Like if you're just not oxygenating well, you have to circulate more in order to oxygenate your blood. And so we finally figured out that you have like an exercise-induced asthma thing, and you've had that since you were young, and you've just kind of muscled through it.
Yeah.
And so we gave you an inhaler, and you're like, game changer. I can work out and I can do things like I didn't used to be able to do. And it's so interesting, it's so simple, but because I know you pretty well, and we're hanging out and we're listening to your story, we can kind of like get past the surface level, get into the more details things, and really figure things out. Conversely, I'll say that urgent care is you don't have continuity there.
I would never go to an urgent care doc and say, hey, my heart rate was at 180 when I was on a jog the other day.
Yeah.
Do you think maybe that's a problem?
Yeah.
Well, nobody would do that, because you only go to the urgent care if you need stitches.
Yeah. Well, but you can also go to your family doctor if you need stitches, and you can go to your family doctor if you have all these other things.
Yeah.
The phenomenon of urgent care has been kind of newer, and the reason why is because these family docs are busier and busier, not necessarily caring for people, sadly. They're documenting, they're doing the triple Bs, which people have heard me say, the bureaucratic box checking bullcrap. And they're just really swamped with a lot of things that pull them away from taking care of people urgently. Oh, sorry, he's scheduled out 3 weeks, right?
Yeah.
And we don't do that at Voyage Clinics. We are available. You can come in that day, next day. We took care of 2 walk-ins today, and so that's part of our mission, is to be their urgent need doc as well as their family doc. So because it's different, like if you go to an urgent care, that person doesn't know you, and they don't trust you, and you don't trust them really. Mm-hmm. And often these urgent cares are staffed with people with like 1,500 hours of training instead of 15,000 hours of training. And there's nothing wrong with that, but it's just a different standard of care. And so I think that's tough.
Yeah, that's... I think of a lot of instances in raising our children when, had I not understood or had a family doc in the family, I would have maybe not gone in for medical attention at all. I remember one incident when our youngest son was probably 5 or 6, maybe even younger, and we were walking somewhere up like a ramp, and it had a wooden railing that had not been sanded in a long time, and he was just sort of sliding his hand along the railing and slid it right into a splinter, like right into his fingernail. It was so deep. And that was bad news. So what did I do? Take him to the doctor's office to take the splinter out, right? And I don't know what I would have done without having a doctor. Probably gone home, tried to pull it out myself with tweezers. Ben just, like, he would have screamed a lot more than he already did, you know? It's uncomfortable, and who knows if I would have gotten it all, right? So I think there are definitely some massive advantages that I see to having access to a family physician while I'm raising my kids, that I think Voyage Clinics provides that same access to all of these moms raising their kids,
So today we talked a little bit about the role of a family doc, the training of a family doc. What is a family doc? And then how to utilize that family doc. And largely we talk about urgencies, maybe some chronic disease management. I have weight issues. I have knee pain. I have neck pain. Also prevention. I want to speak to that space. All family physicians were board certified in family medicine, and part of our objective is prevention of cancers, of heart disease, of strokes, of all kinds of things. And there are guidelines to help prevent some of those things. And so,
Sure.
so that's the other thing you can go to your family doc for is prevention. Hey doc, I just want to do my annual wellness visit and talk about prevention. I'm 55, do I need a colonoscopy? Do I need lung cancer screening? Do I need skin cancer screening? And so we do all those screenings very routinely and order those things and mammographies and all the things to help people live long, healthy lives. That's one of our objectives. Not only to treat the urgencies, I've done stitches on almost all my kids, but also fracture care, but also prevention and also like managing of chronic conditions. Like there's some people that have autoimmune diseases that don't have a cure. And so, we help them manage their medicines or manage various things to kind of help them live reasonable lives. And it's been really, I think it's one of the more satisfying careers of medicine. There's a lot of different types of careers out there, rheumatology, radiology and all these things. And more people are getting more and more specialized. I only operate on the left adrenal gland, Like, what in the world?
Yeah.
Family docs is nice to have. It's also nice to have somebody who understands all of the system, right? They understand the hospital. I understand the ER. I understand, and not just the care that goes on there and their objectives, but also the financial pieces there. That brings me to our next discussion point, which is advocacy.
Yeah.
In this very convoluted healthcare system, we have a responsibility and an opportunity to really advocate for our clients, both from a care standpoint, from a cost standpoint, and even somewhat from a coverage standpoint. Under very, very, very few physicians actually know what things cost. Very few.
Yeah, I've noticed.
And it's really hard. Do you have a quick story about that?
Keep going. I'll jump in.
Okay. She has a fun story that she'll share in a minute. But it's really tough. One of the things that I did all through my training is always took a vested interest in what things cost. I'm like, well, what does that cost? Or what do we charge for that? And how does that work? The billing and the coding and the business of healthcare, I think 1% of doctors understands. And that's why I was like, it's part of my education. I want to understand that so I can advocate for my patients in this way. Now, for 6 years, I've been only doing that, right? So I've been understanding what is the cash price of that, of this, and helping my clients navigate to more cost-effective solutions out there for them. And one of the reasons for that is because a lot of that cost responsibility has been placed squarely on the shoulders of the patients, right? The people. And through co-pays and deductibles and co-insurance, this new gimmick called co-insurance, I just love that. And so now we're financially responsible for this $3,000 per person, $15,000 per family deductible plan that I have that my employer provides for me. What that means is I just don't go in. I try to pull the sticker out of my kid's nail and I fail and it gets infected and then it's an ER visit and then it's, thousands of dollars. And so we're trying to fix that piece of the healthcare equation for people and really advocate for them every step of the way. You were going to talk about cost.
Do you want me to tell my story about cost?
Brief.
Okay, be really brief. No names. Not going to mention any names. One of my children went in for a surgery. It was a fairly routine surgery.
Tonsillectomy.
And we're cash pay because I'm trying to be a conscientious consumer of healthcare. It's not all like magic dollars. It's like real money. Anyway. So I go in and I have to pay for the facility up front. So for this surgery, there's several different charges. There's one that the surgery center charges. That's the facility fee. There's one that
none of the doctors make money on that.
Nope, that's just the center, right? There's one that the surgeon charges, and then there's one that the anesthesiologist charges. And so I had to pay the facility fee up front, and they told me that I would get a 40% discount for paying cash up front, but a discount off of what price? And, nobody discloses that. So I pay that discount. And then the anesthesiologist just comes up with this random big round number, and I have to pay that up front before they can do the surgery. And then the surgeon, like their office, has no idea what it's going to cost, what it's going to be billed at. I don't pay that till later. So we go in and we do the surgery. And then I have a health share. So the health share is not insurance, but it does help reimburse for some of the costs of care. So the health share is looking at my bills and then reimbursing me. But in order to reimburse me, they need an itemized bill, which has CPT codes, procedure codes for things that were done. They can't reimburse me unless I can show the procedure codes. So here I am trying to learn how to read and understand medical coding and language.
And you're a lawyer.
I'm a lawyer.
With an MBA.
Yes.
And it's still extremely convoluted.
So I get a bill from the surgeon's office, not the surgeon directly, because the surgeon has no idea what is charged. The surgeon shows up, does the surgery, the office bills for that.
Surgeon's a great guy.
Yeah, great guy. So,
but there's a disconnect from his billing and coding department.
So I'm looking at the charges for this surgery, and I happened to look at, it was an itemized bill. That means it had the procedure codes for the different things that the surgeon did. So I can look up that code on the Center for Medicaid and Medicare Services, like the national government website. I can look up that code and find out how much Medicare pays for that. This is how much Medicare will say, you know what, we can do it for this much, and that's what you get. And so the doctor's like, okay, I'll take that, and they do the surgery. So the office was charging me like for one of the procedures, they were charging me 1,000 times what they collect from Medicare. And then the other one, it was like, I don't know, something 250 times what they would collect from Medicare. And then they gave me a discount. It ended up being 400 times as much, 400% of what they would charge for Medicare. And so I called the billing department. I couldn't talk to anybody. Nobody has, they're, what are you talking about? What's CPT codes? I don't even know what those are. I'm not a decision maker in this. Like, there's nothing I can do. Well, can you send me to a manager? No, that's like a different department. Everything's in a silo, right? All he does is set me up on a payment plan. That's all he can do. And if I'm not going to pay, well, then, So then I called a health share. And they have no idea either. They're like, well, I mean, you got a cash discount, so I guess you just have to pay the rest and then we'll reimburse you. And I'm like, this is money coming out of your pocket because I already, I paid for it and then you reimburse me. But there's nothing they can do either. It's this game of the shell game, that they do in the park. They hide the bills, they hide the codes, they hide the money. And then as a consumer, I have no tools to be able to advocate for myself and my own pocketbook, even though I'm trying my best to be a conscientious consumer of healthcare. I shouldn't have to pay 400% more than what the doctor will accept from Medicare.
Yeah.
I mean, I can do 150% more. I guess Medicare pays on the lower end of the pay scale. But it's just completely opaque. And trying to navigate that in spite of my level of sophistication is just it makes you want to pull your hair out. Honestly, it does.
Oh man, we need to have a whole podcast on this.
I know.
I want to talk to this. The reason I can speak openly here, just to my audience, the reason I can speak openly here is because I have no contracts with Aetna, Cigna, Blue Cross, Select Health, none of these people. I have zero contracts with anybody. If I did, I would be gagged right now to be able to talk about anything.
Yeah.
It's called collusion, and they actually, there's laws against it, and it's so wonky, and it's wrong.
Yeah.
They're deliberately trying to hide the cheese, right? I like the shell game that you mentioned. It's probably coconuts for me, but moving the coconut heads, they're just moving it around. So let's speak openly to this because I can. I'm one of one doctor. Probably there's not very many of us in the nation who can speak openly like this. Here it is. You ready? Okay. fee schedule. What some medical service that I do costs. Okay. Medicare created a fee schedule across the board, and Medicare tends to be the lowest payer or the benchmark of payers. Medicaid used to pay quite a bit less than Medicare, actually, which was why most doctors were seeing Medicaid patients at a loss.
Yeah.
But let's just talk Medicare. Medicare fee schedule is where we all come up with, I did your tonsillectomy, it's going to cost this much. I did this much anesthesia, it's going to cost this much. Most the time, we in the office or hospitals or clinics or whomever, they create a fee schedule that's a percentage of Medicare. Now, from all the payers, Blue Cross, Cigna, Aetna, Select Health, you can only collect a percentage of that amount that you charge. And if you charge less than 200% of Medicare, then they will pay you even less. So most clinics charge 250% of Medicare is pretty typical. So they're charging 250% of Medicare across the board.
Yeah.
So for a basic office visit, to give you an idea, a basic office visit, it might be $78. It's called a 99213. It's an E&M code, evaluation management code. And for a 99214, it's maybe like $140. And so that's what Medicare pays for those kind of encounters. Those are the most common encounters in doctors' offices. Most doctors are billing twice that and only collecting that amount from Medicare. Now, the payers, what about Select Health, Blue Cross, Cigna, Aetna? There was never a payer in the history of payers that ever paid 200%, 400% of Medicare. None. So you as a cash patient, they're giving you a 40% discount, but they're actually billing is, if what you're saying is accurate, is quite unethical, is quite way above what the typical billing practices are.
Right.
And so, but nobody knows that because nobody knows that 250% of Medicare is like what you bill. Now, what you collect. So all these clinics bill 250% of Medicare, but what they actually collect is anywhere from 100% of Medicare from Medicare to Cigna, Aetna, Blue Cross, Select Health, et cetera. Those people might pay 140% of Medicare, 150% of Medicare. 180% of Medicare is considered extremely excellent collections. Yet you, a cash paying patient, just paid 400%.
I paid 400% of Medicare. Woohoo! Because you got to take it from the little guy when the big guys have too many.
I like how fast you're being, but frankly, they just don't know. It's not malice. Your surgeon is not a malicious person.
I don't think so.
He just has no idea what their billing practices are. And so is this billing company being ethical? Is the hospital being ethical on the amount that they're billing and sticking you with? When Blue Cross pays them $2,000 for this procedure, and yet from you, they collect $6,000, that is unethical. So I think if I'm advocating for all of you out there and you're trying to figure out, hey, I'm cash pay, can you charge me something reasonable, right? They're going to say, oh, we'll give you a 20% discount if you pay today. 20% discount of what?
Right.
They're giving you a 20% discount of a 1,000% markup.
Right.
That's crazy. Yeah. No payer pays. They never collect that much from anyone else. So why are they doing it to you? Frankly, it's because they don't know.
Because they can.
No. It's because the person that's collecting the money doesn't know. They don't know.
Yeah.
If you can just scale it up 3 layers deep in their organization, you can get to somebody then say, hey, can I just pay you what Blue Cross pays you? And they'll say, yeah, I guess you're cash pay. I should give you at least the discount that I give Blue Cross.
Yeah.
Why not?
Especially because you don't have to bill Blue Cross and then wait 30 to 60 days and then have the claim denied and then rework the claim and then finally get the money 90 days later.
Yeah.
You can get it from me right now,
and
today.
They might bill 150, 180% of Medicare.
Yeah.
I mean, they might collect that much from what they bill.
Eventually.
Yeah.
Yeah.
Even better, if you want to negotiate, you'd say, can I just pay you what Medicare pays you? Please, I'm cash pay. That would be a decent ask, actually. Mm-hmm. Will you please accept what Medicare pays you? And when they say yes, then like Shaunna is more sophisticated than the average person. She went online and found the Medicare rates for these CPT codes.
Yeah.
Do you remember the website?
No, it
That's
was
okay.
some cms.gov
Yeah,
somewhere.
cms.gov, and then you could like find
Yeah.
the
Yeah.
CPT codes.
Yep.
CPT codes are procedure codes. E&M codes are management codes.
Yeah.
That's just a nuanced thing. But if you can go to these, if you're self-pay or you have a health share or whatever, and you can say, hey, will you just please accept Medicare payment from me, please? The same amount.
Yeah.
And they say no. Will you just 150% of Medicare? Is that okay? And they say yes. Then you say, here's your money, right? It is way better than their 20, 30, 40% discount that they just gave you.
Yeah.
Because even a 40% discount on 250% of Medicare is 210% of Medicare. And they don't collect that from anyone else. They don't. No
Yeah.
one collects that. And their collections are about 95% if they're very effective, 90% if they're less effective. 95% collections means 95% of the time you collect on it. 5% of the time you collect zero money. So be happy. We're cash. We're paying you today. Collect Medicare rate, please. And that's how you advocate for yourself from a financial standpoint in the system if you're cash pay. Can you tell me what the Medicare rate is for this? Can I pay that, please? If they're not, can I pay 150% of that?
Yeah.
Don't settle for the little discount silliness.
So then let's bring this discussion back around. As a family physician in this unique direct primary care model, how can you help advocate for your patients' pocketbooks?
Yeah, we do this routinely every day in many, many, many ways. So there's some really transparent, one of our missions at the Voyage Clinics is affordable, transparent, good healthcare. And so we have found pathways to get affordable, transparent imaging, pathology, surgeries, all these things that are more affordable, more transparent ways. So one is go to a surgical center, don't go to a hospital. Hospitals charge way more. Surgical centers tend to charge less, although we went to a surgical center and got screwed. So so know how to self-advocate with the Medicare distribution piece, but then also know what is more than the other. So let me give you an example. A guy had a hernia. He's a great guy. And he says, hey, doc, I'm going to go get this hernia fixed. I'm like, great, let me refer you to the surgeon. I referred him to the surgeon. And on the referral, I said, patient is cash pay. Please give him the best deal possible. The surgeon then, again, no malice on the surgeon's part. The surgeon has a sexy little machine called a Da Vinci. And he's like, oh, I can use this Da Vinci thing, and it's going to be minimally invasive, and your recovery is going to be about the same. And and it's going to cost you $26,000. And I said to the surgeon, I was like, so the dentist comes back to me. He's like, hey, man, or he's a dentist. He's a patient of mine. He says, hey, what's this about? I said, well, you could do that. Or you could do it open, which is an incision this long instead of this long. And
so 2 inches instead of 1 inch.
Yeah, 2 inches instead of 1 inch or less. And your recovery is about the same. And the cost is about $6,000. And to him, it was a no-brainer. Like, that's very obvious. But it's only because I know those things. I just tell him. So the next person that had a hernia, I said, tell them you don't want the Da Vinci thing. So they did. Yeah. And I said, tell them you don't want to do it in the hospital. So they did. And they got way better pricing. We have already negotiated pricing for labs, for x-rays, for MRIs, for pathology. Today I removed a large mass from a guy's scalp. And it was a great big old lipoma. And we don't need to send that to pathology. But the procedure, if he did it somewhere else, probably would have cost him $400 to $600. And it cost him $30 at my office because we bill for the Vicryl because it's an expensive suture. And so we're just building that into his membership at Voyage. Yeah. And that procedure saved him more than half of his annual membership with us. And our goal is to be his advocate for the next 20 years, not just the next 2 months. And so that's why we do it the way that we do it. And it works out to be better for everybody.
Yeah.
One patient went to the ER. She was miscarrying. She called me up. It was the evening time. I said, it sounds like you're miscarrying. you need to go to the emergency department because you're bleeding bad. So she went. They ruled out ectopic pregnancy, which is what I wanted them to do. I called the ER doc beforehand. This is part of the advocacy, right? Oh, I'm available, advocating for my patient in real time. Then I call the ER doc. I say, hey, doc, how's it going? I got a patient. She's coming in. She's bleeding. She's in pain. And she's pregnant. I want to rule out ectopic and then manage the miscarriage, right? And he says, okay. And so he sees her, gets things squared away. No ectopic pregnancy, so that's good. No surgery needed at that time. And then sends her home with no pain medicine. And she goes home. 2 hours later, starts cramping again because she's still miscarrying, and then goes back to the ER. Again, this is only because I know the system. I've worked in the ER. I delivered babies for 10 years. I know all these things. I know that when a patient leaves a facility and goes back within 24 hours, insurance doesn't cover that. They don't pay for it. Mm-hmm. They consider it what's called a bounce back, and they don't cover it. And so months later, the patient comes to me and says, hey, remember that time I had the miscarriage? And I say, yeah. And she says, well, they covered the first time I went there, but the second time I went back, they're trying to bill me $1,800 for that. And I said, what? And so I talked to her about it. And obstetrics is billed under emergency Medicaid, which is another like arm of Medicaid that covers a mama who shows up with a miscarriage or in labor and hadn't had any care and didn't have sign up for anything. So it's actually a covered entity from the state. Mm-hmm. And so it was already covered under emergency Medicaid. The second time she came in, for some reason, they missed it and they didn't bill it correctly. And so the patient calls the billing department. I said, you should call the billing department. Calls billing department. I said, put me in on that. So she calls me on a 3-way call. Uh-huh. And so it took us 3 layers of people. No, you don't know what you're talking about. I need to talk to your manager. Nope, you're still a dummy. I need to talk to your manager. Okay, thank you. Finally talked to somebody who knew what they were talking about. And I said, this is what happened. And they're like, wait, who are you? I'm their family physician. What? What are you doing on the phone? I'm just trying to help this patient. I'm trying to figure this out for them with you because I know the system. They don't, right?
Yeah.
And most docs actually don't know the system either, so it's a bummer. But we got on the phone, we talked back and forth, and the billing person said, this was an error on our part. And I told her, I said, listen, like you were about to send this patient to collections. Like you need to look at your systems, look at that, and please let this never happen again. This hurts my people. I love my people. And so anyway, that's just another way. I don't do that for everybody. I don't get on the phone for the billing department of all hospitals or anything. But I do know the system enough to know if it's bullcrap, right?
Right.
Hey, that's bullcrap. That should not happen.
Yeah.
Let's keep working that equation. So they'll often bring things to my attention, and I'll be able to help them navigate those spaces. Yeah.
Yeah. I want to be a conscientious consumer of my own healthcare. I'm a conscientious consumer of everything else. I don't go to the grocery store, and buy all the dragon fruit because that's a terrible analogy. I watch my budget everywhere else, right? Like I'm careful about, tell the kids, hey, turn off the light. Were you born in a barn, right? You get conscientious about your electricity use because that's money out of your pocket. And healthcare spend is actually like massive. And I think it's on each one of us. And we want to control our healthcare spending the way we control our spending in all these other areas. Mm. But it can be very difficult without somebody who knows the system, who can help you, who can teach you, and who can advocate for you and maybe guide you a little bit.
One thing we talked about was really, we're talking about advocating for people from a financial standpoint. I want to talk about advocating people as their family physician from a care standpoint. So healthcare, the care part of healthcare in the United States is continuing to change, right? It's evolving. And in my opinion, it's somewhat evolving toward some subpar standards. And so how can we as family physicians advocate for our clients in that space? I'll just share with you a couple examples. One is just making sure that we're getting reputable labs, reputable imaging, reputable consultations, right? When I send somebody for a consultation, if that doc does a poor job, then I don't send to him anymore. I'm like, no, like you were a total jerk to my patient. You spent 5 minutes and you didn't actually answer any of their questions.
Yeah.
So guess what? You're no longer getting any of my clients. We're going somewhere else. And so that's good. That's like capitalism at work, right? So you can't be a jerk and expect to continue to gain new clients, right? As a specialist.
Yeah.
The other piece that I really struggle with is I refer somebody to a neurosurgeon because I'm like, you have radiculopathy, you're in tremendous pain, you can barely walk, and you're having muscle weakness. Like this is a clear state where neurosurgery is a necessary referral. I send them to neurosurgery, and they see a PA, a physician assistant, and they don't even see the neurosurgeon. They come back to me, and I'm like, whoa, what? You didn't see the neurosurgeon? No, I just saw their PA, and they told me I'll be fine. They gave me a prescription of Lyrica or gabapentin. And I go back and I say, whoa. I'll actually call the office. I'll call the office. Hey, I need to talk to this doctor, please. What? Yeah, this is Dr. Sanders. I need to speak with the physician. It's called a doctor to doctor. Mm-hmm. And doctors do this to each other sometimes when it's a serious deal. And it's normal. So the doc pulls out of the room, comes on, pops on the phone with me. And I say, listen, when I refer somebody to you, I want them to see you. Your expertise, your brain cells is what I'm asking for. I don't want them to see your PA. If you do this again, I won't refer anybody to you again. And they're like, I understand. I said, thank you. Bye. That's it. And it's a mm-hmm. direct conversation. He can handle it. They can handle it. We're tough guys. We guys and gals, like we talk this way to each other all the time, and it is normal. But if we allow for subpar care to proliferate in America and don't advocate for higher standards for our clients, it will continue to deteriorate. Most of your ERs, most of your urgent cares are now staffed with people who are less expensive to staff with.
So tell me why seeing a neurologist PA is different than seeing a neurosurgeon. And I know, but our audience might not know.
Yeah, there's no such thing as a neurologist PA. There's such thing as a neurologist's PA. So just to be clear about that, mm-hmm. some of these PAs and nurse practitioners are describing themselves as, I'm a dermatologist PA. And it's just not real. That is not true.
Okay, so what's the difference? What's the difference between the PA and the neurosurgeon?
So the PA has gone to some undergrad work of some kind, graduated with a degree from any university. The neurosurgeon did as well. The PA then went on for 2 years of medical training. They did rotations. They did 1 year of book work, 1 year of rotations.
Okay.
And that's great. And then they worked with this neurosurgeon to do X, Y, and Z things and become reasonably competent at those things. And that's great. I do not hate PAs. I do not hate nurse practitioners. I think they're wonderful humans. But the training is different. The neurosurgeon went to 4 years of undergrad, 4 years of medical school, mm-hmm. 2 years of book work, 2 years of rotations, then went on to 5 years of general surgery residency, and then an additional, I think it's 2 more years of neurosurgery specific like that's all they did was neurosurgery during that time. Mm-hmm. So you're talking probably close to 40,000 hours of training. And so instead of like 1,600 to 2,000 hours of training, and that's just training alone, not to mention experience on top of that. It's not to say that PAs and nurse practitioners can't become reasonably competent out there by just experience alone, and that is wonderful. But as a family physician with a reasonable amount of training in all spaces, I want subspecialty care for my clients when I send them to a subspecialist. And that means the specialist, not the specialist's PA.
Okay.
Yeah. Super important. And again, like ER as well. So I send somebody to the ER. When I send somebody to the ER, I call the ER doctor and I say, I want you to see my patient, please. This is what's going on. It's a big deal. And that's it. I've already evaluated them. This kid is very suspicious for appendicitis. I sent one yesterday.
Okay.
And he's like, oh, okay, I got you. I'll wait for him. I'll be here.
Yeah.
That way they're queued up and they're ready, right? And that's just good care. That resonates with good care. If they just show up without that phone call, they may sit in that waiting room for a while. They may see somebody through the fast track, the urgent care of that ER, and that's not a physician.
Yeah.
And they may get X, Y, and Z diagnosis and be sent home. And then I give the ER doc my cell number. Hey, call me when you're done and let me know what your thoughts are if you would like me to do something as they go home. And I just think that's really great care.
It's good to know that you do that for all your clients, because being married to a doctor, it's kind of natural for me to assume that, oh yeah, like if one of our children needs to be admitted, like when our oldest son had to go to the ER for a broken face. And so you called the ER ahead of time to let them know, but you don't just do that for your own children or your family. You do that for all of your patients. I've got a stroke patient coming in. I think is having a stroke. Get the crash cart ready, or this patient with appendicitis. So I think that it's good to know that as a family physician, you operate as an advocate for all of your patients the same way you operate as an advocate for your own family.
Yeah, true.
Yeah.
I want to talk briefly about privacy.
Okay.
There are some laws around privacy, and I think a lot of people don't know that their information, medical healthcare information, is being mined very consistently. Part of the Not So Affordable Care Act, I jokingly call it that, part of that was this other law that came into play at that time when electronic health records were becoming very expensive, but the government wanted to force everybody into the electronic healthcare space so that they can mine data. And most clinics were like, why? Well, we've been taking really good care of people for a long time. Why would we want to adopt this new thing? Well, then in order to put a carrot out there, they said, we'll help pay for it. And they created a law called the Meaningful Use Law. and right, they name it something that if you don't comply, you feel like a jerk.
That's lawyer talk, meaningful use.
Yeah, totally meaningful
Yes.
use. So you're not meaningfully using your EHR. So they do this thing, help you pay for it, subsidize the payment of your EHR for so many years. But there's a caveat to it. The caveat was, and again, 98% of electronic health records now complied with this standard of electronic health record. It gave them backdoor access to your information, to your healthcare data. And they can mine it and they can pull it and do whatever they want and extrapolate. And they don't disclose who they're going to sell it to, and they don't disclose what they're going to do with it. And I was the electronic healthcare champion of my hospital at this time when all this craziness was happening. And they're like, oh, we got to adopt an EHR. And we have to do this and this, and it's so expensive, we can't afford it. We got to do this thing. We got to have the government to help pay for it. And I said, yeah, but what about that backdoor access to data part? Like, isn't that immoral and unethical? They're not even telling us what they're going to do with it. They're going to sell it to like big pharma. Like, who are they selling this to? They still have not disclosed that. They have not been very open about that and what they're doing with that data. But almost all hospitals, I would venture to say all, okay, almost all hospitals and clinics are backdoor accessible to the government with your information. And that's really tricky. That's really tricky. My clinic, because I'm outside of all those entities, is not that. I am not backdoor accessible to anybody's anything. So again, we're advocating for people, but I believe in patient privacy. I believe that patient data should not just be mined by anybody who's out there. Like, I think that's silly. So my electronic health record deliberately cut off that backdoor access, which I like, and we're just cowboys and we're like, well, let's do it. But I think it's right. I think it's the right thing for people, and Americans should be able to choose whether they give their data to the government or not. And I just think that's silly.
Okay.
Can you speak to high-tech law a little bit?
High-tech is... it's a more recent law, kind of an add-on to HIPAA law, which is Health Insurance Portability and Accountability Act. It was passed in the 90s. and high tech is designed to give patients a little bit more privacy. It's been a while since I read through the law, but from my recollections, under high tech law, you can prohibit certain covered entities, which are different kind of businesses, often insurance companies. You can prohibit them from having complete access to your health record.
Yep.
If you pay cash for medical services, right? So if I'm a patient and I'm paying you cash for a visit, then even if I have health insurance, why should the health insurance company be privy to the information contained in that treatment plan or that visit? They shouldn't, because they are not part of that transaction. They're not paying for it. Therefore, they don't have any right to the data involved in that transaction. And so high tech just codifies that patient right to privacy and to prohibiting outside entities from gaining access to their protected health information when that outside entity has no relationship, financial or otherwise, with the doctor and the patient.
So because Voyage clinics and other direct primary care clinics out there have these direct financial agreements, the ones that are pure direct primary care, not hybrid practices that do take insurance, we don't do anything with insurance. So therefore, insurance companies have no rights to any of our data, any of the patient's information.
Correct.
Which may increase the cost of their premiums, increase the cost of their copays, deductibles,
Sure.
if they were to disclose those things. So again, I think that's kind of cool. It's kind of a neat advocacy role that we kind of play as well in the direct primary care space. I will just say caveat wise that this does not include life insurance, however.
Right.
You can't, if you
'Cause that's
refuse to
different.
disclose everything to a life insurance company, you have to disclose that you're not disclosing all of your health records. That is a different subset of laws. But this subset of laws, high-tech law, is around Blue Cross, Cigna, Aetna, Select Health, all these payers, right? The major
Right.
insurance payers,
Yeah.
and their ability to access your information.
Right.
That's
If
cool.
they're not involved in paying for your care, then they have no rights to access information about your care
That's really
because
cool.
they're not even a party at all.
Yeah, that's really cool.
So-
That's really cool.
Okay.
I'll say just one last thing. I think we're getting close to time here, but the last topic I want to really talk about is just being holistic, and holistic has like a couple different ways of looking at it. Like holistic minded family physicians, we're all trained to be that. We're all trained to look at the 10,000 foot view and then go into the microscopic view and then pull back to the 10,000 foot view, see the patient as a whole, see their biopsychosocial components of whatever's going on with them. Because there are absolutely things that are more than just science going on with people. And so I think what's neat about like Voyage clinics and other direct primary care clinics where we're not transactionally based, we're not fraught with all the bureaucratic box checking bull crap, we're not hustling through patients per hour, we're not doing any of that stuff. We're sitting and we're spending time with people, is that we can now be more holistic minded. We can think more broadly. We can really deploy more brain cells. And I'll just give you one brief example. Today I saw this cute little kiddo, 8-year-old kiddo. Mom brings him in and she's concerned about his emotions. Like he gets really depressed, he gets really anxious and has a hard time regulating. And so we talked about it. And I asked him, first I just asked him how he's doing. What does he like to do? What are his fun hobbies and interests? And he finally started to kind of open up and banter back and forth, and we talked. And one of the things I do is I train medical students. So year round, I'm a professor at a few different medical schools, and I like training, I like teaching. And this medical student's sitting there and listening, and we're just having a good conversation. And we talk about, like, mom is very concerned. She's like, well, I talked to him about his emotions and he tells me this and he tells me that. And you could feel the despair in her voice. Like, I don't know what to do. She says she's an emotional coach. She does lots of emotional coaching and talking and helping people. And she's very knowledgeable, very, 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 very sophisticated. And she says, I've done all the things and I still can't help this kiddo. So, my doctor brain said, oof, I don't love the idea of starting an 8-year-old on a medicine right away.